Welcome back to another edition of It's Your Health. I'm here with my brother, Dr. Dan Benyo. We got a lot of requests that we did a wonderful show, at least.
Excellent.
I got a lot of hate mail too. We'll be filling your televisions with a lot of fun information over the next half hour, so stay tuned. We'll be back after these brief messages. Welcome back to the first segment of It's Your Health. Remember, anything we talk about, you need to check with your doctor first. I would check like maybe 2 or 3 times, especially for the things that he says, just to make sure.
Possibly.
This is a useful, informative show. And how do we always get started?
Headlines.
Headlines. All right, let's move on. U.S. death rates from chronic liver disease continue to rise.
Yeah, we're starting to see an increase in abnormal liver function. It's thought not only to be related to alcohol, which was the primary issue several decades ago, but now we're starting to see fatty liver disease as a primary component that's kind of nudged out hepatitis C with liver deaths.
Yeah, we'll talk about that more because I think we're seeing more and more of that in over the last 5 years, and I think that's something that was worth, maybe we'll expand on more. This is an exciting headline. Cigarette smoking falls to its lowest level ever.
Yes, I think everyone's very excited that smoking now is kind of not as sexy or interesting as it used to be several decades ago. However, there is a little caveat to that.
That's right. That's cigarette use. We didn't talk about e-cigarettes or vapes, but we're seeing 51% of the nation's 10 million e-cigarette users are under the age of 35. That's really scary. We're seeing a much younger population being attracted to this, quote, safer but not really considered safe alternative.
Yeah, it's almost a gateway to cigarette use, so it's unfortunate.
Right. Novel theory may explain SSRI's variable efficacy in major depression.
Very interesting, and I'm sure you've seen this as well. We start people on antidepressants and they may or may not work. People go through a couple of them and they already have this kind of negative outlook towards SSRI therapy, and this kind of shows that you need a positive outlook, positive environment when you start these medications to get the best outcome of them.
Yeah, I agree. It's a lot of its expectation. If you really expect to fail, you're never going to give it a chance because it takes weeks for these things to start working. And if you kind of have that negative outlook, all you're going to experience is side effects and not give it its full effort. I agree. You have to have a positive outlook. And I think that's why therapy sometimes is helpful too, because that helps kind of dovetail that. Now let's change it up a little bit, and we're going to talk about some of the newer things that are happening in cardiovascular disease. You know, we used to think about primary prevention for stroke and heart attack. What do? You get your cholesterol down, you lose weight, you take an aspirin. And that was it. You know, we didn't have a lot else. If your cholesterol was high, take a cholesterol pill like a statin, and that would help lower it. But we're starting to find more and more it's not just about those pills. There are other things that help lower stroke and heart attack risks that really don't, to me, associate with stroke and heart attack, like a lot of different diabetes medications.
Oh, certainly. Those SGLT inhibitors are one of them, Jardiance being the very publicized and commercialized medication that lowers cardiovascular risk. You know, an interesting fact is, if you're healthy, you work out, you exercise, you're at goal weight, you don't smoke, you don't drink, you have a 50% chance of having coronary lesions, even doing everything perfect. And it's a pretty interesting fact. So these newer medications that are oral, relatively tolerated well, are effective, and some of the other ones are the other diabetic meds that are injectable, the GLP-1 agonists, Ozempic, Trulicity, also reduce cardiovascular benefit. And there's a common cholesterol med that now we're using, and you like to use it a lot as well.
Right, that's Repatha. What's interesting is I used to be somewhat really negative on some of the newer cholesterol medications because they didn't show lowering cardiovascular disease. There was a med that came out about 10 years ago that was not a statin but helped lower cholesterol, and we were really excited that it would help lower cholesterol and hopefully lower stroke and heart attack risk, because we kind of thought that those two were tied together. And it turned out it really didn't lower your stroke and heart attack risk at all, but it lowered your cholesterol, so we're just treating a number. But these PSK9 inhibitors, which are an injectable, yes, I get that, it's an injectable, cholesterol medication, but they'll take someone's bad cholesterol of 200, which is extremely high, very high risk for stroke and heart attack at those levels. After a month of therapy, your LDL is down around 40. You know, they do an amazing job. They do also, it took a year for them to do the studies and the data, but they show that they do indeed lower stroke and heart attack risk, kind of almost independent of that cholesterol. So it's an important add-on when we look at people who may have already had a stent put in. What are we really doing to maximize their cardiovascular risk reduction? It used to be cholesterol pill, aspirin. That was it. But now there's a lot of other things we can do that really have, it doesn't seem like they have a lot to do with heart problems, but ensure they do.
Oh, certainly.
Alrighty, so we talked about it earlier in the headlines. We talked about non-alcoholic fatty liver disease, or NASH. Let's talk about a little bit about what that means and kind of what we need to do about it. And how do we look for it?
We're seeing a lot of it now. Non-alcoholic fatty liver disease, basically causing inflammation in the liver. NASH is a subtext of it, and it's non-alcoholic steatohepatitis. Sounds very fancy, but it's more severe inflammation in the liver. And it's usually seen in people who are obese, also diabetic, have high cholesterol, kind of going back to what we just talked about. And it can actually, if gone unchecked, can cause cirrhosis, which is indistinguishable from alcoholic cirrhosis, which has severe mortality rates. And so there's not many medications that we use for it. People looked at metformin, it hasn't really brought benefit. Pioglitazone, which is an older medication we don't use as much anymore, vitamin E. The biggest risk reduction is losing that weight and modifying those risk factors.
Right. It's certainly something we see more and more, and when it was first starting to come, at least across my desk, it got kind of confusing, because when I would see these type of liver changes, I was like, well, I mean, you know, if you have cirrhosis, you drink. That's it, or you have hepatitis C. And if you don't have those, then you probably drink and aren't telling me. But it turns out there's a much greater population now that is expanding. And as our diabetic base expands, our obesity base expands, we're going to see a lot more of this.
Oh, certainly.
And it's difficult because I don't have a magic bullet to sit pill-wise to say, well, this will just cure this. It doesn't work that way. But it has very irreversible changes later in life.
Oh, yeah.
All right, emails.
Yeah, I got an email the other day, and maybe you can answer this or assist with this. Someone's going for a cardiac stress test. They don't quite know if they're able to walk through it because it's physically demanding. What are some of the other ways they can do a cardiac stress test?
Well, I think if it's physically demanding in the sense that you might get out of breath or have chest pain, you need to get that stress test. That's a bigger problem. But let's say you have knee pain or you have hip pain or back pain, and you're just not going to be able to get on that treadmill and do what we need you to do. That's fine. We have ways that you can literally sit down, and we give you some medication that's going to speed up that heart to the rate that we wanted. We're able to then use medication to see how that is penetrating the heart, to see if there's any blockages, and you're able to do the whole test sitting down. Is it as accurate as a physiologic stress test or getting on the treadmill? I think it's always better if you can, and make the part of the stress test limit you being you're having shortness of breath or you're getting fatigued. That's fine. I want that to be the limiting factor. I don't want your knee to be the limiting factor. I don't want to hear, you know, Phil, I tried to do that stress test. I only could last 2 minutes because my back started to hurt. That's a problem for me because I'm not going to get the results I need.
Oh, sure.
But there is a way.
Oh, sure.
Well, I'm getting the sign. That's the first segment. It's up and done. Let's break for a couple of messages and we'll get back to some more headlines here on It's Your Health. Welcome back to the second segment of It's Your Health, your leader in healthcare information. I didn't mention that before, but I
think it's assumed.
I owe it to our population. Let's get back to some headlines. Risk of atrial fibrillation increased in migraine with aura.
Yeah, I came across this and it was pretty interesting. We run across a lot of patients with migraines, and one of the questions we ask is, do you have an aura? Sometimes that can be laid on by an odd sensorum or sensation, seeing things, hearing things that kind of precede the migraine itself, and it was actually associated with atrial fibrillation. So it kind of, if they're positive on that aura question, may require some further workup.
That's interesting. I kind of always would stop there, but it's something to certainly look into a little bit more. Obesity has stopped the progress on cardiovascular disease.
So, tying into our segment, the first segment, we see that we've made big strides with cardiovascular risk reduction. However, obesity rates rise, and that has kind of stalled out the progress that has been made on reducing cardiovascular risk.
Interesting. Makes sense.
Sure.
Makes sense.
Sure.
Go into the next headline. Exercise tied to lower depression risk among older adults.
Sure. I think this is kind of well known. If you exercise more, you're less depressed. You're getting outside. You're interacting with other individuals who may improve your sensation and your thought process. And so it's not a surprise that it does that.
Yeah, we exercise, release good endorphins. Those are good pathways to have. I think that makes a lot of sense. Exercise is never going to hurt anything.
Oh, certainly.
Let's talk about when exercise does get a little bit further along. And I always, I think I could write a novel on the excuses I've heard to not exercise. And one of the most common ones is my feet hurt. I can't do that. My feet hurt in the morning. When I get out of bed, I could barely walk. What are some of the common foot problems that we run into?
Most common is a case that you see someone who's increased their activity more than their usual baseline. They want to make a change in their life that everyone is applauding. And here they start to get really tenderness and pain along the bottom of their foot. And a very common problem we find is plantar fasciitis. And some people, when I say that word, cringe because they understand how much pain and discomfort there is. And there's some simple steps you can do at home to kind of treat it. And that's stretching exercises, really extending that bottom part of your foot, rolling on a ball. Sometimes NSAIDs, ibuprofen, Aleve, Motrin, but always talk to your provider before using that. And then just keeping active as well. Those are kind of the big proponents of plantar fasciitis. It's very, very painful, and sometimes we inject it, but that kind of makes it even more painful.
Right. Injection, I think, is the last resort for that.
Certainly.
That's one of the common things. I actually had similar issues, and I was using all the good tricks, and it just wasn't getting better for me. And so what I had to do, I went and saw a foot doctor. And she took a look at my feet and says, "Phil, you have flat feet." And I was like, oh, my heart beats still.
I knew that.
It's terrible. And but what did she do? She got an orthotic made for me that I will not walk barefoot for a minute without wearing my inserts. They don't hurt, they feel great, and I can do all the crazy stuff that I used to do, jumping around, doing just wild stuff, and my feet don't bother me at all. If I go a half a day without wearing those because I change shoes or something, I'm crippled. I could barely walk. It's always worth getting it looked at. Flat foot Phil. Yeah.
That's what we used to call you.
Yeah, I don't remember that, but maybe it was when I turned my head. Alrighty, a little question. I've had a couple patients say this, and I'm not sure if it's true or not. My migraines are getting worse when the weather changes. Now, I've heard arthritis will get worse. My knee will get worse when it gets stiff, or I can tell when there's a front coming. But let's talk about changes like in the weather, sunlight. What are some things that can actually trigger migraines? Is that true?
Sure. We've always heard this, the rain's coming, or it's too bright, and certainly there are certain sensations that can trigger a migraine. I know instance, certain foods can trigger migraines, so certainly environment, allergies can as well. It's really based on vasoconstriction and pressure changes. Those can all worsen migraines. There's not much to do about it when the weather is changing, except to avoid it, or if you're on abortive therapy or maintenance therapy, kind of monitor that and see if it needs adjusting.
Alrighty, so I don't know about your wife. My wife goes to I call them oil parties, and they're not the parties I think they're going to be. But they're parties that, they end up getting essential oil kits and packs, and they come home with all these crazy oils, and they're going to cure everything with these oils. And so one of the ones that has come up, more than once is, will oil of oregano help treat a sinus infection?
Sure, it'll help my dinner with pasta. That's what I use it on.
That's delicious.
It is. I have never heard of it treating sinusitis, and I wonder if when we talk about sinusitis, we talk about what causes it. Is it bacterial from bacteria? Is it a virus? Is it from smoking that causes chronic irritation of the sinus passages? Is it from allergies? So it's not quite clear oil of oregano is the treatment of sinusitis. I've never heard that and probably wouldn't prescribe it. I don't see much harm in it, though, if it does work for you.
I think the inhalation use of essential oils is in that, it shouldn't hurt you. I don't know if it's going to help you, but it shouldn't hurt you. And every now and then, if she uses peppermint oil or something in your little stuffy, well, that opens you right up. That feels great. I start to call in question when people start ingesting oils. I think that's a problem because, at least the pills I prescribe, the pills you prescribe, I know where they've been. I know how they're manufactured. I know the FDA is up their rear ends watching every single way they make it. And when there's a mistake made, we all get to read about it in the news. This falls under natural supplements, which are not regulated. Who knows what's going into this? You don't know what the strength is. You have no idea what's actually happening. And so that's the one thing that's dangerous, to ingest into your body something that's coming from an unregulated factory. That's where I kind of come in to have a problem. You want to rub something on your skin, I don't think you're going to get in trouble.
And sometimes we use Vicks Vapor Rub. Some people use boiled onions, or pot in the bed, or boyo is another form of
and now you're starting to sound
supplement.
like my father.
There you go.
He's a fan of that stuff. Alrighty, well, that's the second segment. We're just about wrapping it up, and we're going to take another break, and we'll be back with the third segment in just a moment after these brief commercial messages. Welcome back to the third and final segment of It's Your Health, your leader in healthcare information. We're going to start getting back into some headlines, and I think we're going to start with a headline that really kind of is something we've talked about before, but now they can prove it. All right, PPI use is not linked to cognitive decline.
Sure. It used to be these over-the-counter and prescription-based acid reducers, such as omeprazole, Prilosec, Protonix, Nexium, put you at risk for cognitive decline, dementia being the big one. However, this study goes to show that they aren't really linked at all, and it's quite unclear what that prior study was trying to associate with.
Yeah, the prior study we actually talked about probably about 2 years ago. It's where you heard it first on It's Your Health. I'm sure we were the first people to talk about it.
They remember it.
I'm sure they do. And we had talked about that and said, they did a study, and the way they did the study is they didn't actually put people on proton pump inhibitors and see whether or not they became demented. Is they looked at a nursing home population and they associated things, and they saw that people with dementia had a higher chance of being on a proton pump inhibitor. They didn't say it caused it, but boy, they put the two close enough together that people got really upset. Now, we are able to see that proton pump inhibitors aren't quite as safe as we used to think. We used to say you can stay on them forever, it's safe, no problem. Now we're seeing increased risk of osteoporosis and osteopenia, higher fracture risk. That stuff makes sense. This didn't really make a lot of sense. The same study also showed that they had increased risk of aspiration pneumonia. Well, which came first? Was it they're getting GERD and aspirated and they're on a proton pump inhibitor in the first place, or did it actually cause it? I don't think so. I think we'll see that get refuted as well. But certainly I think from a long-term standpoint, any medication you're going to be on long-term, you should look at the risk factors, long-term. But dementia is not one of them for a proton pump inhibitor. Moving on. This is neat. 2/3 of COPD patients are not using their inhalers correctly.
When I saw this headline, I thought of you, Phil, because you are a big proponent of using device training while in the office and making sure that these COPD patients, other patients as well that are using other devices, are using the device correctly. Because if the common complaint is, doc, these inhalers aren't doing anything, they're very expensive, what's going on, what do we need to do? And sometimes it's as easy as, well, how are you using the inhaler?
Yeah, I agree. It's inhalers. You get 1 second to get it right, and if you don't get it right, you just wasted it, and who knows what's going to happen. But also the risk of side effects are higher. And you're right. These are expensive. They're coming out with new inhalers every day, and they are really wild combinations. There's some really good stuff out there. Some of the newest ones are combining 3 different inhalers in one. That's a real time saver and money saver for patients, even though they're more expensive. It's 1 copay as opposed to 3. But device training is really important, because if you're not getting that dose right, you're really wasting your money. Lastly, sucralose upregulates fat genes in high BMI users.
Yes, this is kind of, when we talk about diet, when we talk about nutrition, there's a lot of interesting data out there. And it used to be low fat, high carb. Then we went to different zone type of diets. Then we went to kind of low carb, high fat. Regardless, we're finding that a lot of artificial sweeteners are doing more harm than using regular sugar or just no sugar at all. And this sucralose, which is found in a lot of artificial sweeteners, upregulates the fat receptors in the body, and people who are pre-diabetic, obese, or diabetic are the ones who actually gain more weight when they eat other foods that contain fat, because there's upregulation of these fat receptors. So it's counterintuitive to what the current trend is.
I think, there's been studies to show that there's some problems here. This is a little bit more linking it as to why there's a problem. We know diet soda causes weight gain. Kind of doesn't make sense. And we've talked about some of the pathways for that, how it has a higher binding affinity on your tongue, so when you actually have something that's sweet, you need more sugar to make up for that, because the Splenda or the aspartame is a lot more affinity for your tongue. And also your body's ready for sugar. It pumps out insulin, and then guess what? It doesn't get sugar. Drops your blood sugar. What are you going to do when your sugar drops? You're going to go have something to eat. Probably a mistake. So I get that part, but this actually shows there's some genetic issues with this. And this really does speak home to me, because I've cut I used to be a 4 Splenda coffee guy. I've cut down to 2, but it seems like I just got to cut it out and just go hardcore. But there's other things I have with Splenda in, so this certainly is this explains my alarming obesity.
This hits home. This hits home.
Little yellow sugar packet, that's what's screwing me.
Flat feet and the sugar packets.
The yellow ones,
yes,
that's bad.
The yellow ones.
So I got to change that. Alrighty. Let's change gears a little bit. We've been in some heavy topics, and let's kind of get a little bit more hands-on here and talk about acute hand infections. There's a lot of red bumps and lumps you can get on your hands, and let's kind of separate them all out and talk about what is it something you got to come see us about. Excuse me. What is something you can just deal with at home?
Sure. There's we talked about foot infections and foot problems in the past segment, and a lot of common hand problems we see that I've had patients say, well, doc, I didn't want to see, I didn't think it was that big of a deal, and it turns out it is a big deal. And then other ones where it's kind of maybe some home management would have been affected prior to seeing your provider. Big ones that you always have to watch out for are infections. So when we talk about infections or bites, it's an animal bite. Cat bites, very dangerous. That's not something to just sit at home and say, oh, my cat bit me. I'm just going to sit at home and soak it in warm water. You could lose your hand on it because the cat has bacteria that can be dangerous, and then as well as their teeth are very sharp and can actually puncture some of the joint areas and maybe even break off a tooth in the joint, which is extremely dangerous. And then there's dog bites. And then human bites, we call it a fight bite. When someone hits their knuckle in someone's tooth, and the human mouth has a lot of bacteria as well. Yours more than mine, of course. But you can at least get, it's a significant risk factor. You can lose your hand from it if it goes unchecked. And certainly need to see providers for that. You can get paronychia, which is just an infection around the nail bed, the cuticle, that can be easily treated at home, but always kind of go to your provider if it's starting to get more red and swollen.
How about like when someone has like a little blister along the side of their finger and they're worried it's getting infected, but it's kind of white, maybe a little clear, has a little bit of an irregular shape. Sometimes people will see a couple of them, like little bubbles.
They may be a dental assistant or dentist themselves. Sometimes you can get a little herpetic whitlow, which is basically herpes on your finger. That should always come into the office and be evaluated for. You can take antivirals for it. If someone has oral herpes simplex, that's one way they get it on their finger. And if it spreads unchecked, it certainly can go into the bloodstream and be a significant infection.
Another thing, just to kind of back up to, I feel from a safety standpoint with animal bites, is it's always important to, if you're bitten by any animal, really find out about that vaccine status of that animal. If that animal has not had a rabies shot, you're getting committed to getting rabies shots. You have to do it. Rabies is 100% fatal in humans. It is not something to fool around with. And we actually had a patient last year, was bitten by a feral cat. She thought it was fine, wasn't going to do anything. She finds out, she goes to the ER on our advice, gets her shots, which are expensive, but 2 days later finds that cat dead on her porch, sends it off to the lab, and that cat had rabies. And so it can happen, and if she didn't get that taken care of, you know, she would have rabies and she wouldn't be here today. So that's something that's really important for, dog bites, cat bites, you have to confirm that rabies status. And if you don't have it, go to the ER, they will treat you. That about wraps up the end of our third segment. We're really, we have more topics. I guess we're going to have to just get that into the next show. You're going to have to tune in next month. Thank you all for coming.
Thank you. Yeah.
And we look forward to seeing you again. If you have any questions, make sure you email Samsung Productions. Check out their website, their Facebook. They have like every social media possible, and they can get it to us. That's about it.
Fastest 30 minutes in TV time.
All right. We'll see you later on
It's Your Health.
Health.